Now let us see about anesthesia in a liver disease patient on a gross. First, we'll ask the patient his symptoms if there is any anorexia, nausea, vomiting, weight loss, how is his urine and stool and its color. So we'll go for symptoms first, and next in PAC, routine PAC will ask us comorbidities, any previous history of jaundice, any bleeding tendencies. Mainly, we'll also ask about previous surgical history and his recovery during that. So, any jaundice and bleeding tendencies and previous surgery and blood transfusions are important. And the most important is his personal history about his addictions, any drug addictions, alcohol consumption, sexual promiscuity, etc. Now we'll go for examination. Routine examination will be doing about his airway, spine, and dentition and all. And especially we have to see for presence of jaundice, asterixis, Palmar erythemia. Now we'll go for vitals. In vitals, pulse, we'll see his pulse rate because there might be bounding pulse because of hyperdynamic circulation or anemia. And in BP, there might be decreased diastolic blood pressure because there is diastolic dysfunction. And we have to see his baseline SpO2 because there might be hypoxemia also. And after that, we'll see his labs, including routine CBP, LFTs, LFT with liver enzymes, RFT, his serum albumin level, his coagulation profile, his chest X-ray, 2D echo, and the actual liver scans, ultrasound or CT scan, whatever had been done to diagnose the etiology. And added to that, we'll see his previous urine output. How was his urine output? If he's already catheterized, it's okay. Otherwise, we'll ask him how many times he's able to pass his urine and all. Now, after knowing all the things, I'll risk analyze the patient. So, risk analysis is very much important whether to give this case or optimize this case, postpone this case, or cancel the case. So, we have two main scores, CTP score and MEL score. Now that I have risk analyzed the patient, I'll go for surgery. So, I have decided to give this case. Now, what I'll do is, firstly, I'll do the optimization and pre-op orders. Okay. So, in all system wise, I'll see for optimization, may it be respiratory system infections or cardiac wise his status or his coagulation profile or electrolyte imbalances, acid base imbalances, everything. I'll optimize. I'll go for a nasogastric tube decompression and then I'll get ready for the OT. I'll check my entire OT for emergency drugs and all. I'll check my Boyle's machine and I'll attach the monitors to the patient, NIPP, pulse rate, SpO2, ECG. And apart from that, depending on the case, I will go for CBP or transesophageal echo, neuromuscular monitoring because I shouldn't give overdose of neuromuscular blocking drugs. Now, I'll start the pre-oxygenation because adequate pre-oxygenation is very much necessary because we have already seen that there might be decreased FRC due to massive ascites if it is a cirrhotic patient. Coming to pre-medication, we'll go for your glycopyrrolate, ondansetron, and in the opioids. Please be careful because then if we give more amount of opioid, he might land into drowsiness and also encephalopathy too. So we'll avoid morphine, meperidine. Fentanyl is relatively safe, but if we have remifentanil, we are more than happy. Okay, coming to induction agents. TPS, in liver disease, there is decreased plasma proteins, so there will be increased unbound fraction, so more effects. So better we'll go for with propofol if his hemodynamics are stable. Otherwise, we'll go for other options, ketamine or etomidate in cardiac patients. Right, coming to muscle relaxants. Obviously, we'll go for HRAC or cis-HRAC because it is organ independent metabolism. If we give VEC, we have to be very careful under neuromuscular monitoring only we have to give and decrease doses. But HJAK or cis-HJAK is very much preferable in liver disease. Coming to succinylcholine, if you wanted to do rapid sequence intubation, right? There is decreased amount of plasma cholinesterases in these patients and liver disease patients. So there will be increased effect of your succinylcholine. So what we'll do is either we'll decrease the dose and in mild and moderate diseases, this increasing effect is not much seen clinically. So in mild and moderate diseases, we'll give off succinylcholine as usual, but in severe, definitely we have to decrease the dose. So have done with the neuromuscular blockade. Now reversal. Your neostigmine with any anticholinergic, glycopyrrolate mostly. So the duration of action of both of these are prolonged. So it's okay to give your routine reversal. But Sugamadex is the best choice. It's the best. So almost I have completed the case, but throughout I'll be monitoring the case. My goals will be there shouldn't be decrease of hepatic blood flow. There shouldn't be any hypoxia, hypocapnia, and excess sympathetic stimulation. And I should never use hepatotoxic or nephrotoxic drugs. Okay. So with these goals, I'll be doing this monitoring the patient during the surgery. And the main thing is I'll also monitor urine output, temperature, and blood sugars because there might be hypoglycemia. Okay. So post-op, I'll see about his pain management, any infections, and surgery-related complications, and other complications like post-op. There might be any spasm or respiratory system-wise complications and liver-related complications and coagulopathies also. So this, on a whole, is my management for a liver disease patient. Now let us see in detail. In PAC, we have already seen the risk factors: alcohol, drugs, herbal products, tattoos. Tattoos also we have to ask: sexual promiscuity, consumption of seafood, raw seafood, and travel to areas where hepatitis is endemic. We'll ask us symptoms: fatigue, anorexia, weight loss, nausea, vomiting, pruritus, dark colored urine, abdominal distension, any GI bleeds. This is also very much important. And we'll see for the signs: icterus, palmaremia, gynecomastia, ascites, petechiae, ecchymosis, astraxis, testicular atrophy, and there might be bounding pulse and decreased diastolic BP. And also prior episodes of jaundice and surgical and anesthetic procedures will ask him. Lab investigations, your CBC, BGT. BGT is very much important because there might be any blood transfusions needed during the surgery. LFT, liver enzymes, RFTs, electrolytes, sugars of the patient, chest X-ray, ECG, 2D echo, ABG. For baseline oxygenation of the patient, ultrasound abdomen, fibroscan, and viral markers. If there is increased liver enzymes, we have to know for the cause. Okay. So now I'll risk analyze the patient. First, I'll know the etiology. If it is an elective surgery, we'll postpone in the patient with active hepatitis. If the patient is in a state of active hepatitis, I won't be doing an elective procedure now. So, but in cases of CLD, it is not feasible to postpone because the recovery is very much delayed. So, I'll see the prognostic factors. I'll risk analyze the patient by firstly, there used to be child Turcot score in which there are 5 factors: albumin, bilirubin, ascites, encephalopathy, and nutritional status. See, these 5 how I remembered was I used to watch Friends series. In that, Ross's son name is Ben. So how I remember is AA Ben. So this is ascites, albumin, bilirubin, encephalopathy, and nutritional status. You might have your own things, but I used to remember it in this way. But this nutritional status is replaced by PT and also along with INR to some. So this modification was done by Pug and it is called modified Child's Pug score. But even this modified Child Pug score has some disadvantages because it is subjective. This ascites and encephalopathy are subjective ones. So I'll grade the ascites in one way or encephalopathy in one way, the other person will grade in another way. So these are subjective. And second is they have ceiling effect and cutoff values are arbitrary. That means, see here, the bilirubin of less than 2 is an A class, but the bilirubin of greater than 3, might it be 5 or even 10? It belongs to C. So there is no higher grades. Even 5 and 10 also same, they come under same category. So those are the disadvantage of modified child birth score. So there is MEL score for that. In that, subjective elements like your ascites and encephalopathy are replaced with objective elements INR and serum creatinine. So this is your MEL score. That is 9.57 into log creatinine, the value of creatinine, plus 3.78 the value of bilirubin, and plus 7.2 into value of INR, plus 6.43. These are logarithmic values, please remember. How I remember this was, one second. How I remember this was, I remember in the form of a phone number. Okay, that's CVR. Okay, first three, next three, and this three. So I remembered it in the form of the phone number and I'll give CBR. That means creatinine, logarithm value of creatinine, bilirubin, and INR plus 6.43. Everything will have decimal. 11.2, 1.12, and 6.43. Okay. In this way, I have remembered. So overall, we will get one score. If the score is less than 11, it is said to be have no post-op mortality, and greater than 20, it is contraindicated for elective procedures until and unless liver transplant is done. Apart from this, there are two more other factors, age and ASA grading. If the age is greater than 70, we have to add 3 MEL points, and if the ASA is greater than 4, we have to add 5 MEL points. There are further modifications to MELD. They are MELD sodium, integrated MELD score, which includes serum albumin and age of the patient. And in pediatric group, it is called as PELD, pediatric MELD score. So there are other scores apart from the CTP and MELD, vocal pen score and Mayo Clinic post-op mortality risk calculator. So on a whole, these are the scores which we use for risk analysis, and there is a correlation between MELD and CTP. If the MELD score is less than 10, it correlates with class A of CTP. If it is 10 to 14, it correlates with class B, and if it's greater than 14, it correlates with class C or grade C. So on a whole, outcome factors, they depend on the stage of liver disease, stage of cirrhosis, presence of associated complications, the type of surgery, the age of the patient, and has comorbidities. So this is your child score and modified child birth score. So these are some of the drugs which are associated with liver disease, including in analgesics, acetaminophen and NSAIDs. In cardiovascular system, there are statins, amiodarone, methyl dopa, antimicrobials, isoniazid, rifampicin, pyrazinamide, tetracyclines, macrolides, and neurological epileptics, phenytoin. Please remember this because we routinely use these drugs. Okay, valproate and recreational drugs like cocaine, amphetamines. Okay. So, I have taken the history, I have risk analyzed the patient, I have seen if he is taking any hepatotoxic drugs, have stopped those drugs, and now I'll go for pre-op optimization, including I'll treat any active infection, I'll optimize his renal status and central blood volume, because in these patients the effective blood volume is decreased. I'll improve his encephalopathy and coagulopathy status. I'll correct any electrolyte imbalances. If there is any nutritional deficiency, I'll do its correction. I'll optimize his CVS and respiratory system wise complications. I'll avoid any hepatotoxic and nephrotoxic drugs. And nasogastric tube decompression and gut sterilization is very much important. Okay. Then we'll give pre-op orders, and my anesthetic goals will be to prevent the decrease of hepatic blood flow. That means I have to maintain a normal hepatic blood flow. I should avoid sympathetic stimulation, hypotension, hypocapnia, pressure effects. I should avoid hypotension, hepatic venous congestion. Of course, I'll be avoiding hepatotoxic drugs. Coming to intra monitoring, apart from routine monitoring, I might use arterial pressure monitoring, CBP monitoring, pulmonary catheterization, transesophageal echocardiographic tech, and neuromuscular monitoring, depending on the severity of the liver disease and the type of the case. So, selection of the technique. So, what are my concerns in regional, GA, and nerve block? In regional, I'm afraid of coagulopathy and hypotension mainly. So, due to regional anesthesia, there might be decrease in hepatic blood flow. If the block is higher, there will be more decrease in hepatic blood flow. And coagulopathy and thrombocytopenia should be checked before giving uraxial anesthesia. In GA, my concerns are aspiration risk because there will be massive ascites. There might be massive ascites and multiple drugs have to be used. And in nerve blockade, I'm very much happy if the coagulation profile and everything is normal, and where the nerve block is feasible, I can go with nerve blockade. All my hemodynamics will be maintained. Coming to general anesthesia, the main problem is the metabolism of drugs is decreased due to decrease in functional hepatocytes and also decrease in hepatic blood flow. Either it's already present, or I might induce the decrease in hepatic blood flow by induction of anesthesia. If there is any hemorrhage during the surgery, opening of abdomen, retraction of the abdomen, use of PEEP, IPPV, everything, they cause decrease in hepatic blood flow, which in turn affects your metabolism of drugs. So finally, what are the factors which affect the clearance of the drugs are blood flow to the liver, obviously the hepatic blood flow, fraction of drug unbound, and the intrinsic clearance. So there is a concept called extraction ratio over here. Please concentrate. It is nothing but it is the fraction of inflowing drug extracted by the liver. That means if there are 10 molecules of drugs going into the liver, out of the liver, some metabolism has been done in the liver, and from the liver, almost 2 molecules have come out. So this is the concentration at the inflow, this is the concentration at the outflow. So what will be the ratio? 10 minus 2 by 10. 8 by 10, almost 0.8. Okay? Now, we'll see drugs with high extraction ratio and low extraction ratio. What happens with drugs with high extraction ratio is the change in liver blood flow produces obviously the change in clearance, but it is unaffected by hepatic capacity. That means I am the liver. Okay? You have given me some work to do. I have good capacity to do that work, that specific work, because I have high extraction ratio. If you give me 10 things to do, I can easily do 8 things out of 10 things. So my capacity is good to do that things. So the overall outcome, the overall result will depend on how much work you give to me. That means if you give 20, I'll be doing 16. Okay. If you give 30, I'll be doing 24. Right? So the work increases if you give me good amount of inflow, good work. If you give me more work, I'll do more work. Okay. So this limits on your flow. That means if you decrease the work you give me, if you decrease the flow to me, I can't do more work. But because I have good capacity, okay, to that specific work. If you give me another work, which I'm not that much interested in, and I don't have that much capacity, that means its extraction ratio is less. If 10 molecules go in, 8 molecules are coming out. Extraction ratio is almost 0.2. That is decreased extraction ratio. Now, whatever amount you give me, might it be 10, 20, 30, you keep on increasing also, I can't do. Right? My capacity related to this work is decreased. So here it is capacity limited. So you have to give me the second level of work after some time because I'm very much slow at it. I'll take time. Okay, in the first scenario, my capacity is good. So if you give more, I can do more. So that is flow limited. In the second scenario, my capacity is less. So if you keep on giving me, my burden will increase. I can't do anything. So you have to give me some time to do that work. So it is capacity limited. Okay. So this two is very important. High extraction ratio, it is flow limited. That means here we have to decrease the dose. So if you give me, I'm affected now. I I have said regarding normal liver. Now I am affected. This is diseased liver. So now in the high extraction ratio drugs, you have to decrease the dose. So if you give me lesser amount, obviously I'll do fine. But in low extraction ratio, you have to give me time. That means you have to increase the dosing interval. Okay. So two types, high extraction, low extraction. High extraction is your flow limited. In that what we have to do is decrease the dose. Low extraction is capacity limited. In that you have to increase the dosing interval. The examples being high extraction ratio drugs are propofol and pentothiosin, and low extraction ratio are your TPS, phenytoin, alphentanil, acetaminophen. So there will be decreased proteins in liver disease. So increased unbound drug fraction. So increased free fraction leading to enhanced effects. So there will be increased free fraction of the drugs and also volume of distribution is also increased. Both are increased. Free fraction of the drug and volume of distribution. But sensitivity to the drugs is also increased, especially in patients with encephalopathy. So this is on a gross pharmacokinetics and pharmacodynamics of drugs and liver disease. Coming to what I'll choose. Opioids, obviously metabolism is decreased. So we have to increase the dosing intervals, otherwise it will worsen your encephalopathy. Morphine, meperidine are avoided. Fentanyl we have to give in lower doses. Remifentanil is very much good because it is hydrolyzed by blood and tissue esterases and independent of hepatic function. Coming to induction agents, we have already seen TPS. Due to decreased plasma proteins, there will be increased unbound fraction of the drug. So those should be grossly decreased. We have a better choice, propofol, and a titrated doses. Muscle relaxants, vicuronium and rocuronium, there will be prolonged duration of action, and also there will be resistance to the initial doses. If we have to give it, we have to give a titrated dose and a neuromuscular monitoring. Etrac and cisetrac are very much good because they are organ independent elimination. But the lordosin of etracurium has to be eliminated by the liver, which is neurotoxic. So, in liver disease, the lordosin cannot be eliminated. Neurotoxicity might increase, but all this scenario is not seen clinically. So, we can use etracurium. Suxamitonia, uh, because of decreased plasmacholinesterase activity, its effect might be increased, but it is also not clinically significant in mild and moderate diseases. In severe, of course, we have to decrease the dose. This is important. If we have to use vasopressors in the middle of the surgery, there will be decreased response. Okay. So, we have already seen in liver disease there is decreased response to sympathetic stimulation and also decreased response to vasopressors and increased response to sedatives. Okay. So, up to some extent, our endogenous vasoconstrictors will help to maintain the BP, right? But in liver disease, what happens? There will be decreased response. So, we are more worried about hypotension. Coming to reversal agent, of course, there is risk of prolonged effects of anticholinesterase and also there is prolonged effect of anticholinergics also. So there won't be residual curarization, but sugammadex is better agent of choice. Volume resuscitation. So fluid and blood products have to be given in a goal-directed manner based on fluid responsiveness. Because in end-stage liver disease, there will be decrease in albumin. We will be giving albumin in only certain cases like after large volume paracentesis, presence of spontaneous bacterial peritonitis, and in HRS type 1. My IV fluid of choice will be a balanced solution like plasma, right? Because in RL, I'm afraid of lactate. If I give continuous normal saline, I'm afraid of hyperchloremic metabolic acidosis. If I'll go with colloid, I'm afraid of renal dysfunction and platelet dysfunction. Because in liver disease, already there is thrombocytopenia and colloid affects your platelets. So, my fluid of choice will be plasmolite, and if I want a good volume expander, I'll go with albumin, but I'll be careful because sudden volume overdose, my heart cannot, the heart of a liver disease patient cannot withstand because it has already systolic and diastolic dysfunction. Coming to pain relief, only in mild disease patients will give lesser dose, otherwise will better to avoid PCM. NSAIDs are of course contraindicated because of nephrotoxicity and also they might present precipitate upper GI bleed and they affect your platelet functions also. So the coagulopathy status is normal and I was able to secure epidural, so I'll go with epidural analgesia or blocks like bilateral tab block. If INR is abnormal, I'll go with the patient controlled analgesia like remifentanil or fentanyl at lower doses. It is better not to use alpha 2 agonists as an additive because they decrease your hepatic blood flow. So post-op complications might include coagulation abnormalities, sepsis, pneumonia. We have to watch for urine output because the patient might land into HRS or AKI. We have to see his mental status. We have to assess the hepatic encephalopathy. We have to avoid hypothermia and he might also develop thrombosis. So mechanical thromboprophylaxis has to be done post-op period. So have taken so much care, but there might be chances for post-op liver dysfunction. This is nothing but increase of hepatic transaminases, that means hepatic liver enzymes, or presence of jaundice or symptoms such as encephalopathy or heart failure. If any symptoms, signs, or labs are showing hepatic dysfunction in post-op period, it is a post-op liver dysfunction. When should I consider? If the increase of this liver enzymes is less than 2 times of normal, it may be transient and it might recover. But more severe increase of these enzymes should caution for hepatocellular injury. That might be due to hypoxemia or trauma, surgical causes, or any bacterial insult, any sepsis and all. So, post-op liver dysfunction, that is liver is not functioning now. What might be the reason? For any organ to function, it should have oxygen. So hypoxemia. And the second thing, otherwise, someone is damaging the organ. So trauma, surgical factors of trauma. And again, if this is post-op liver dysfunction, nothing but your jaundice, post-op jaundice, right? Whether it is unconjugated or conjugated. So we'll divide the causes in these 4 subheadings: hypoxemia, surgical trauma, unconjugated, and conjugated hyperbilirubinemia. Coming to hypoxemia, that might be due to atelectasis, pneumonia, that means both heart and lung might cause hypoxemia, right? So heart failure, pneumonia and atelectasis, or decreased BP, hypoperfusion or anemia, because your hemoglobin has to carry the oxygen and there has to be good flow, good BP has to be there. So these are the reasons for hypoxemia. Coming to surgery, if there is decreased hepatic blood flow during surgery due to retractors or your IPPV, PEEP, any reabsorption of traumatic or surgical hematomas, hepatic resection, or during cardiac surgery, if there is a pre-existing liver disease, if the patient has undergone a cardiac surgery, okay, that might worsen your liver disease. Coming to the causes of unconjugated hyperbilirubinemia, blood transfusion reactions, hemolysis like hemoglobinopathies, metabolic defects, erythrocyte metabolic defects, Gilbert syndrome, Crigel-Najjar syndrome, etc. And coming to conjugated, it might be hepatocellular disease, pre-existing liver disease, trauma, and Dubin-Johnson syndrome. So, my conclusion plan will be if the patient is having a liver disease, if it is a new onset, first I will evaluate for an elective surgery. If it is a pre-existing liver disease, I'll assess the risk of the patient. For elective, if it is a child, if it belongs to child A or B, I'll optimize and I'll post for the surgery. And if it is a child C, I will defer the surgery until liver transplantation. All this in elective high risk procedures. Okay.